before we get started this morning, just to kind of remind everybody that after today, after this morning, I will not be here this week. I am available by text, by email. Please feel free if you need something, if you have a question. Send me a text, send me an email, and I'll be checking those frequently. If you have a question about some of the lecture content, something you didn't understand, by all means, please let me know. The other thing I wanted to say is, since you do have a test Monday, next Monday, and you won't see me after today, I am willing, if you all are interested, if you're not, that's fine too. I did this once before when I had to be out of town for something. If I'm willing to have like a Zoom meeting this weekend for anybody who would want to. If you just have questions about the content, if you didn't want to review something, since I'm not going to be here to ask questions, if that's something that a number of you would be interested in, I'm certainly willing to do it. Obviously, I can't reteach the content, but I can answer questions, review anything that's confusing. So is that something, there enough of you who want to do that? We're doing it. How many of you would be interested in doing that, let's say, if we did it on a Saturday sometime? What I would do is I would record it so that for people who have to work, you can listen to it on your own. So would y'all be interested in that? Yes, no, don't care. Okay, I'll tell you what I'll do is I will, I'll go ahead and plan to do it on Saturday, and I will post a time on Blackboard. If you cannot, and I'll send everybody an invite. If you cannot join, that's fine. If you can join, do, and then it will be recorded. And it just depends on what questions you guys have, because obviously you have the content. So I'm not going to reteach anything, but if someone doesn't understand something or just wants clarification on something, this way, you don't have any contact with me after today. So Wednesday's information is kind of on your own. You don't get to ask questions. So I wanted to give everybody the opportunity to ask questions. So we'll tentatively plan to do that for Saturday. Just watch Blackboard, and I'll let you know at a time. And I know no matter what time I pick, there's going to be somebody who can't. I want to do it, and I can't be there, so I'm just going to. Yes.
I'll be out for the military. So
well, they'll be recorded if you want to listen to it. You'll have the opportunity to listen to it. So, if you can't make it, then you can listen to the recording. So, and again, whatever value it is, just depends on how many people log on and what questions you guys ask. But I feel bad that I won't be here, so I'm just trying to offer something to kind of, I don't want anybody to say, oh, if you want to hear all week, I didn't get to ask any questions, and I don't want anybody not doing all their tests because of that. So we'll tentatively plan to do that. So we're going to get through today chapters 3, 5, the rest of 3, and then 5 and 6 hopefully. As I said, if we don't finish chapter 6, I will try to get it recorded tonight and posted as well, but I'm hoping that we get finished with it. And then that would be chapter 7 and 9 are recorded. So that makes your test, just so everybody's clear. Because the test originally, if you look at the course calendar, says chapter 11 is going to be on it as well. There's no way we're going to get there. So your test will be chapters 1, 3, 5, 6, 7, and 9. Okay? 1, 3, 5, 6, 7, 9. Now you may notice when you review, when you look at the chapter compared to the PowerPoint, there's stuff in there we didn't talk about, especially chapter 6. There's a ton of genetics that we don't even touch. So if we don't touch it in class, don't worry about it for testing purposes. This is not a genetics class. Again, as I told you guys, I don't have a whole semester to teach. I can only give you what I think are the most important things that I can get to you in 5.5 weeks. So whatever genetics we talk about in class, that's all you're responsible for. So whatever you come to in the chapter that is not covered in class, it will not be covered on the test. On the flip side of that, as you see, you notice on the PowerPoint that may say see table so-and-so, see page so-and-so. That is a big fat clue to you that is important. If I make the effort, it takes a lot of extra effort to mention a specific page number, because that means every time you get a new book edition, I got to go back in and change all those. So it must be pretty important for us to add specific page numbers and specific tables. So that is a big clue that you need to be reviewing those. Those are important. Let's see. Talk about your lecture for Wednesday. So you all don't need to come in Wednesday at all, of course. Your lecture is on your own. You listen to it on your own. You listen over and over. Whatever your preference is for that. Tomorrow, you guys in my clinical group all know where you're supposed to be, right? So you on email on Friday, everybody get that email, just reiterating where you're supposed to be and what to do. And then for Thursday, then you've got a clinical assignment. And you'll bring that into me next Monday. Okay, any questions about that? So everybody's all set for the week. Okay. All right. So we left off talking about determining ovulation. What we were talking about before is we were talking about things that would enhance the possibility of conception happening. This chapter really is talking about pregnancy occurring. What does it take for pregnancy to occur? Anybody remember where does the majority of the time, where does conception occur? Where? What part of the fallopian tube?
The outer two.
Outer 2/3. 2/3 of the time it happens in the outer 2/3 of the fallopian tube. Exactly. So that's where we expect to see it the majority of the time. We talked about changes in the female body that make it more hospitable to sperm so that conception can occur. Now, in order for all that to happen, the woman must ovulate. And the term ovulation basically means she's releasing an egg from the ovary. That's what ovulation is. The release of an egg from the ovary. It happens every month in normal cases. Are there cases where women don't ovulate for one reason or another? Yes, many, many times. So, the mistaken idea that a woman releases an egg 12 months a year for 35 years, that's not always the case. There are months women don't release eggs. The older they get, the more likely they are to not release eggs or to release bad eggs. Again, we also learned last week that when menses begins early, 12, 13 years old, a lot of females have anovulatory cycles for the first year or so. So there are times that women don't release eggs. You can't get pregnant that month if you don't release an egg. The thing is, you really don't know. Unless you're having ultrasounds every couple of days, to assess whether you've released an egg or not, you don't really know. So determining whether or not you ovulate or how frequent you ovulate or what part of the month you ovulate is a retrospective determination. In other words, you can only figure it out by looking backwards. So here, we're going to talk about how to do that. So for couples who've been trying to conceive and have not had much success, one of the first things that we do, the easy thing to do, is we want to figure out, is the woman ovulating? So we ask her to keep a menstrual chart for a minimum of 3 months, ideally 6 months, because that's a lot of time that passes. But 3 to 6 months menstrual chart. And what she charts is the first day of her menstrual period and what day that is, and then how many days there are in between. So document day 1 of the menstrual cycle, first day of bleeding is day 1. The next time her period starts, that's day 1 of the next cycle. So if day 1 happens and then day 29, then on the 30th day, bleeding starts again, that becomes day 1. Not day 30, but it becomes day 1 again. Right? Does that make sense? Okay. So I'm going to write over here on the board. Put this on for y'all can see this. Okay. Everybody got this? Can I erase this?
Mm-hmm.
Okay. So what we're going to do is she's going to document day 1 of the menstrual cycle here. We have 2 phases of the menstrual cycle. Well, there are some sub-phases too. You don't have to remember those. What I want you to remember, first phase is the follicular phase. F for first, F for follicular. First follicular. Luteal, last for luteal. Luteal is the last phase. Follicular first, luteal last. Those are the 2 phases of the menstrual cycle, the bigger phases. What triggers this one to end and this one to begin? Ovulation. O for ovulation. So bleeding starts here. Most menstrual periods last approximately 5 days. Keep counting across all your days. Ovulation occurs, triggering the follicular phase to end, the luteal phase to begin. Then over here, day 1 occurs again. So the question is, how many days was the whole cycle? Because that's how let's make it easy. Let's say it was a 28-day cycle. Just say 28. Day 1 through 28, and then bleeding starts again over here, so this is a new cycle. So this person had a 28-day cycle. Every woman does not. There are women who have very regular cycles, but not 28 days. We think of 28 days as sort of the regular, but I'd say there probably are less than half the women are actually that regular. If you're on oral contraceptives, you may actually have a period every 28 days, but that is very controlled by the amount of hormones that you're getting in your birth control pill, so that really doesn't count because you're not actually ovulating when you're on the pill. So this is just for people who are not on birth control. If you're on oral contraceptives or some kind of hormone contraceptive, this is not valid for you because you don't ovulate. But if you're having normal cycles, you have follicular phase, ovulation, luteal phase. Okay. So how do we determine what day you ovulate? Well, we know that the luteal phase is fixed. It lasts 14 days. It's a fixed number that lasts 14 days. We know then also that the follicular phase is variable. It can last a variety of, whatever amount of days there are. So in this case, if you have a 28-day cycle, and the luteal phase we know is 14 days, then that leaves the follicular phase also to be 14 days, meaning ovulation occurred on the 14th day. Now, what if change it? The patient didn't have a 28-day cycle, and she had a 32-day cycle here. Okay, she had a 32-day cycle. We know that the luteal phase is always 14 days. That means the follicular phase was how many days?
18.
18 days, means she ovulated on the 18th day. Okay? Do another. Let's say she had a shorter cycle than 18 days. Her cycle was 27 days. You know, the luteal phase is 14 days. The follicular phase then was how many days?
13.
13 means she ovulated on day 13. So you see where we're going with this? So if I ask you on a test, I told you the patient had a 35-day cycle, and she asked you what day she ovulated on, you would tell her that she ovulated on day what? 35-day cycle. She ovulated on day what?
21.
21. Good. You got it, right? Questions? So what you need to know is the menstrual cycle starts with day 1. The luteal phase and the follicular phase are the two phases you need to know. Follicular first, luteal last. Ovulation triggers this one to end, this one begin. This one's always fixed at 14 days. Whatever's left goes over here for the follicular phase. And the length of the follicular phase and ovulation are the same. Those are exactly the same. Okay, questions? Okay, good. So that's basically what's on that slide. Okay, so now let's switch gears a little bit because this is listed in your content. We're going to talk about, we've read all the way through the reproductive life, and now we're on the other end, and we're going to talk just a little bit about menopause. So the average age of menopause in the United States is 51. So that doesn't mean everybody goes through menopause at 51. Some women it's 47, for some it's 53, for some it's 55, but the average is 51 years old in the United States. And again, it's a retrospective diagnosis, meaning we cannot diagnose it until a woman who's in her usually later 40s to 50s has gone through a full year with no menstrual period. And then we can say, oh, now you're in menopause. For example, as I said a few minutes ago, when you get towards the end of your reproductive life, menses sputters and starts and stops. And the reason is because you've got less and less good eggs, so you're ovulating less and less. So you may go 3 months with no period, and then ovulate and have a period. Then you may go 6 months with no period, and then ovulate again and have a period. And so it varies a lot as you're getting towards the end. It's kind of like running out of gas. You just spits and stutters until you get to the end. So only when a whole year has passed can we look back and say, oh yeah, you went into menopause last August because it's now been a year. This is August again. You haven't had a period since last August. So now you can say August of last year is when you entered menopause. But we can't say it until a whole year's gone by. Okay? So menopause represents the end of reproductive ability. It means the woman doesn't have any more eggs. She's not releasing eggs anymore. She can no longer conceive. She can no longer get pregnant. And accompanying menopause are a lot of fairly uncomfortable symptoms for a lot of women. What happens is the estrogen is doing this, and progesterone, but estrogen is really causing most of the symptoms. Estrogen levels are just going down, 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 down. Estrogen estrogen does a lot more things than just help us to have a normal reproductive life. It makes us feel young. It keeps us from getting osteoporosis as females. It helps if you want to even heal emotionally. So estrogen is really an important thing to lose. And so a lot of women, some have more problems than others, but a lot of women have a lot of severe symptoms around the age of menopause, and it's all related to estrogen. We're going to talk about symptoms of menopause. So symptoms of menopause are pretty much listed there, the most common ones, and they are hot flashes, vaginal dryness, anxiety, mood changes, insomnia, headache, depression, osteoporosis, weight gain, irregular vaginal bleeding for reasons I just mentioned, among others. Those are the most common symptoms. So you probably should be able to identify what we typically think of as symptoms that women have during menopause. Now, every woman has a different combination of symptoms. For some, it's more severe than others. For some symptoms are really bad, some are not so bad. So it all varies. So if the reason for the symptoms are loss of estrogen and progesterone, the theory has been, well, let's just replace it. Let's just give them estrogen and progesterone back, and maybe they'll feel normal again. Well, technically speaking, that is true, and it does work. It makes women feel tremendously better. It relieves their symptoms, but there are some really downsides of supplementing women's estrogen and progesterone level when they are menopausal age. There's a reason the female body is designed to stop producing estrogen later in life. What we have learned is, and about 20 years ago, when they went into menopause, every woman got what we call HRT, hormone replacement therapy. It was like you just got it. They just gave you a prescription. Oh, you're going through menopause. Oh, you're having anxiety and hot flashes. Oh, here's your prescription. And we gave it to every woman. We knew it would increase the risk of breast and ovarian cancer. So we didn't give it to women who had high risk of that. But we thought it was protecting them against heart disease because premenopausal women don't usually get heart disease. If you know anything about heart disease, you know that younger women don't have heart attacks very often. It's older women who are postmenopausal. So we thought that estrogen was protecting them against heart disease. They did a huge study. I don't know if you've ever heard of the nurses study. It's women about my age and older, and they did a study of 3,000 nurses over the whole United States that were in an age range, like I said, from my age to probably 6 or 8 years older than me. They learned tons from this study about women's health. I mean, I can't tell you all the things that have changed and been adjusted based on this nurses study. And what they learned is not only did supplementing women with estrogen and progesterone increase their risk of breast and ovarian cancer, we did know that, but not only that's the case, in addition, it also increased their risk of heart disease and stroke, which was a shocking discovery. We had no idea, but it was making it worse. So we stopped prescribing it, just across the board to everybody. So now women do not get HRT or a replacement of estrogen and progesterone. Premarin and Provera are the brand names. Estrogen and progesterone are the generic names. But really, we don't give it routinely anymore at all. Only if the woman's symptoms are severe. And even then, we look at her history. Does she have a history of heart disease in her family? History of cancer in her family? And if not, and her symptoms are severe, like the symptoms are so debilitating it's affecting her life, then we may give her HRT for a few years, but we don't routinely give it. So that's a change. But those are the reasons we gave it, and that's why we don't give it anymore. But what we're giving is estrogen and progesterone to replace what a woman is losing as those levels go down at menopause. So now what we do is just combat the specific symptom. Like if the woman reports depression, give her an SSRI. Sometimes they'll give her temporarily, if she can't sleep, they'll give her temporarily something to help her sleep. So we can combat the specific symptom without trying to bombard her with hormones that may increase her risk of heart disease, stroke, breast cancer, and ovarian. Okay, so that's really all I'll say about menopause. It just, it's in our material to cover. It's kind of the other end of the spectrum, but that's really all you need to know. Okay, so we kind of talked about this already. We talked the other day about barriers to the healthcare system and healthcare disparities. Who has a disparity in terms of care, what populations. So So we talked about gender issues. We all agreed that women had a healthcare disparity for a variety of reasons, cultural issues, financial issues, and that comes down to healthcare disparities and then vulnerable population. So what's a vulnerable population? A group who's prone to have those healthcare disparities. So I think you'll identify that already, so I'm not going to go back through it. Women are vulnerable populations. Children are very vulnerable populations. They're at the mercy of whoever's taking care of them. They don't get their shots. They don't go to the doctor regularly. They don't have good health care. They're at the mercy of whoever is taking care of them. So children are a definite vulnerable population. Single, mothers, patients without insurance, any other, anything else? Elderly people, that's a great one, yes. Elderly people are definitely vulnerable populations as well. Again, sometimes they can't get to the doctor, they can be at the mercy of whoever's helping to take care of them, they can't drive maybe, they're on Medicare, does their doctor take Medicare, on and so on. So all those are vulnerable populations. So we have to think about, those vulnerable populations and how we can best serve them. So what we're going to talk about now for the rest of this chapter is what kind of care is needed at stages of the lifespan for a female. So what care does she need at specific stages? Well, this slide, for example, we're talking about preconception and while she's pregnant, what care does she need? We'll talk about menopausal and other times of life. What kind of health care does a woman need? So for preconception, let's say that you think you want to have, you're going to graduate from nursing school in December, and so you want to have a baby right after that. So this summer, let's say you go to the doctor and you say, I want to get pregnant sometime after December. What should I be doing to help prepare my body so that I'm as healthy as I can possibly be? And that response should be minimize the risk of teratogens. Does everybody know what a teratogen is? What's a teratogen? Something that can cause a defect to a problem to a growing fetus, like medication, alcohol, street drugs, or prescription drugs. A lot of prescription drugs are teratogens, again, it's safe. Pesticides. Anything that it can be harmful to a growing fetus is a teratogen. So minimize the risk of teratogens. Stay away from pesticides. If you know you might be thinking about getting pregnant, don't use alcohol. Stop smoking. The doctor will look at your prescription list and say, this is okay, this one's not okay, we need to change this one, this one's okay. For example, if you have a seizure disorder and you're on Dilantin, they're going to say, no Dilantin, you'll have to substitute that for something else. So if you're thinking about getting pregnant, let's go ahead and switch you to Keppra or something else that is safe for pregnancy. So again, they'll look at your prescription list and determine what's okay, what's not okay. Resolve health issues. The patient's, let's say, obese. And the physician may say, for best chances for both conception and a safe pregnancy, you need to lose some weight because you're obese and all the problems that we associate with obesity, hypertension, diabetes, and so on. If the patient smokes, you need to stop smoking. If they're a type 1 diabetic, let's get your diabetes under control. You're not doing well at managing your blood sugar, and let's get your blood sugars under control before you get pregnant. So we'll be looking at what can we do to maximize the chances that the patient is healthy and can carry a pregnancy safely. Okay, so during pregnancy, we all know that prenatal care is of the utmost importance. It's greatly important that patients go to the doctor on a regular basis when they're pregnant because we're screening for things. We're screening for problems, hopefully to get a chance to catch them before they become big issues or prevent certain problems or identify issues that we can fix if we can just identify them. So prenatal care is very important. So we're screening for mom problems and baby problems as well. And then also manage the patient's labor and delivery. I don't think any patient wants to say, I'll just have the baby home, I don't need a doctor, don't need a midwife, don't need anybody, I can do this by myself. I doubt highly that most of anybody says that. So if for no other reason, patients do tend to seek health care at the time of labor and delivery, if no other time. Those of you guys who have been in clinical with me have seen and discussed patients who are what we call drop-ins. What's a drop-in? Those of you guys who've been with me in clinical. What's a drop-in patient? They just drop in to have the baby. Never seen you before, but here I'm here to have the baby. I think I'm in labor. So they call those drop-ins. And we don't know their due date. We don't know what health problems they might have. We don't know what STIs they might have. We know nothing about them. And so we're seeing more and more of them these days. And the reason is, I think I discussed this before, the reason is mostly is that they know they're going to have a positive drug screen because most of them are drug users. And they know that a positive drug screen equals a CPS visit. And they know they're apt to lose that child or maybe other children that they might have in the home as well. So they avoid prenatal care as long as they possibly can. It's kind of a denial thing. We also may see patients, and this happened a couple weeks ago, I can't remember whose patient it was, somebody, one of your all patients, or the patient was with the nurse. But anyway, this little girl was a teenager and came in and hadn't told her family. Whose patient was that?
It
I
was
don't think
our
that
group.
was, yeah. I don't think it was anybody.
Yeah, it was the nurse had that, the nurse had that another patient like that, and
Yeah,
with,
yeah.
one of you guys were with that nurse, I think. But the patient was 15 or 16 or something and came in and just, was having abdominal pain, and when she didn't even tell them she got to the ER, she got in the hospital that she was pregnant. So her dad didn't know why he was bringing her to the hospital. He was just bringing her to the hospital because she had abdominal pain. And when they got there to the ER, she said, well, by the way, I'm pregnant. And by the way, and so initially they didn't know what dates to give her, so they arbitrarily assigned the date. I don't know what they used, but they would give her a date of like 23 weeks, which is obviously 17 weeks early. But she was contracting and acting like she was in labor, and so then they reevaluated her again and came up with a different date of 35 weeks, which is almost term. And as it turned out, she was almost term. And she had a baby that day. And nobody knew till that morning she was going to have a baby. So those things happen as well. You've probably all seen the TV show, I Didn't Know I Was Pregnant. Y'all seen that show? I don't believe that. I don't buy that for a second. I can't believe you don't know you're pregnant. But denial is huge. Denial is huge. If you don't want to be something, you cannot be something as long as you want to. You can do a lot of things with your mind. So anyway. So those drop-ins, my point is they are not getting prenatal care. So we don't know. There's a lot of things that may be happening. Sometimes I had a patient once who came in seizing, and nobody in her family knew she was pregnant. They just thought she was having a seizure. Never had a seizure before, and she was eclamptic.
Oh, wow.
And term and eclamptic, seizing, had a baby before the family could even get a chance to know she was pregnant. She was in the OR having a baby because she was seizing. So
The parents probably needed to see some patients with medication after that.
I probably would be seizing myself. But seizing. But that, you can imagine how you'd feel if that was your daughter.
Yeah.
That you didn't even know your patient. Not only is you didn't know she's pregnant, but now she's seizing and her life's in jeopardy. And she's having a baby. So that's a lot. That's a lot. Okay. Now on the opposite, maybe you as a
Let me know if I can help.
it's Siri, but I don't know who.
Let
Was
me
my
know if I
watch?
can help.
Yeah, it was. I don't know what I said that triggered her. I heard it, but I can't remember. Okay. So
You're seizing. Let me know if I can help.
So you may, as a nursing student, not be saying I want to have a baby, and as soon as I graduate, you may be saying I don't want to have a baby in the near future. So what do we do about that? So you're going to need to seek medical care for, to control fertility, prevent pregnancy from happening, or maybe you've been trying to have a baby for 2 or 3 years and you need treatment for infertility. Either way, you're going to be seeking health care. So we're going to talk in the next chapter about infertility quite a bit, and we're also going to talk about contraception, interestingly enough. But you may be looking for contraception, or you may be looking for treatment for infertility, either one. But either way, those are reasons to seek health care. You may be seeking health care as a female for menstrual problems. A lot of times the menstrual cycle is it's a bumpy ride sometimes. Sometimes you have irregular cycles. And usually those can all be related back to anovulatory cycles. For women who have irregular periods, that's the main problem, is that you're not ovulating regularly for whatever reason. Maybe you're seeking care for heavy or painful menstrual periods, which is dysmenorrhea, and you're looking for medical care for that. Maybe you're seeking care because you're in the perimenopausal area where you're having all those menopausal symptoms we talked about, or maybe you're going into menopause. And again, the doctor can screen patients and prescribe specifically based on the symptoms, or in certain situations they may want to prescribe hormone replacement therapy depending on the situation. Also screening for specific diseases. STIs or other diseases that are specific to women, or GYN cancers. I'm not covering chapter 4, like I told you guys, which is the GYN chapter, but we can have cervical cancer, which we'll talk about in a few minutes a little bit, uterine cancer, ovarian cancer, several types of reproductive cancer that we would need to screen for. Okay, so when we're doing an assessment of the female, first of all, we always, of course, take a history. Part of that procedure is to take a history, ask the woman what her complaints are, what is she seeking care for today, and then the next thing would be a physical examination. A physical examination consists of a review of systems, not just the reproductive system, but a review of other body systems as well, GI tract, and so on, other urinary urination, other problems. And then for a reproductive type visit, then there's going to be a pelvic examination. Now, in the past, if we had a male practitioner, they did not ever go in the room and do an exam alone with them. We always had a chaperone, so to speak, just for not only the patient's protection, but the doctor's protection. There have been cases where doctors have been accused of things, and if there's another person in the room that can verify that did not happen, that's all good for the male doctor. However, these days we have chaperones, male or female, because there are same-sex relationships, and so just for the safety of everybody, we do not do an exam on an individual unless there's somebody else in the room, for everybody's protection. And if you're in a teaching institution, you might have 5 people, or 6 people, or 7 people in the room, medical students, nursing students, and so on and so on. So you may even have an audience. Okay, so this consists of an external examination, which means we look at the external genitalia. Is it normal for developmental age? If it's an adult, does it look normal? If it's a teenager, does it look normal? Do we see lesions, a sign of a STI? Is there, any kind of lesion that we need to culture or look at or evaluate? And then an internal examination includes a speculum exam, and then what's called a bimanual exam. This picture is a bimanual exam. In the picture, they're pushing down on the uterus up from the abdomen, and then trying to feel the edge of the ovaries and feel the uterus that way. And they're, again, looking for tumors and other things, abnormal anatomy. The speculum exam is when they use an instrument that sort of opens up the vagina and provides visualization of the cervix. So remember I said the vagina is a collapsible muscular tube. So it will kind of collapse in on itself, so the speculum will hold it open and provide a means to see the cervix and evaluate the cervix. And the cervix, why that's important, is we are worried about cervical cancer. So we do screen for cervical cancer using what's called a Pap test. Most people probably have a Pap test. Those of you who are females have probably had a Pap test. Now let me ask you this question, those females in the room. When you had a Pap test, have you been told when you called to schedule it, A, not to come in if you're having your period, and B, not to have intercourse for 24 hours before? Anybody been told that? Raise your hand. You've been told that. Good. That's amazing, because usually women are not told that. Most classes that I ask that question, I get 3 or 4 hands out of all the females in the room. They're not being told that, and so what that does is it just makes for a lot of extra expense and extra anxiety that's not necessary, because those are some specific patient teaching things we can talk about in just a minute. So number 1, a Pap test is for cervical cancer only. This is a real misconception that women have. It does not screen for uterine cancer. It does not screen for ovarian cancer. It screens for one thing: cervical cancer only. That's really important. Not any other type. Because I can't tell you how many women I said, yeah, my Pap test was fine, so I'm all good. Well, you're good for cervical cancer, maybe, but that's it. You could have stage 4 ovarian cancer, and the Pap test wouldn't tell us anything about that. Only for cervical cancer. So what they do is they take a specimen. They take they put a speculum in, take a little sample of tissue right at the cervix, just with a Q-tip, and they put it on a slide and send it to cytology, and cytology looks at that and looks for abnormal cells. So if there are abnormal cells, then they test it further. They do a repeat Pap and something that's just a little more invasive in terms of a test. So for women who have not been told to not come in if they're having bleeding, or who have had vaginal intercourse in the last 24 hours, what happens is sperm can show up like abnormal cells. They can't identify what they are, but it'll just be, the test will come back as something called ASCUS, abnormal cells of unknown significance. And so ASCUS just means basically you got to repeat the test, something's wrong with it, but we really don't know what. So now that means maybe it was just because it was, contaminated by sperm and it just needs to be repeated. Now the patient has to reschedule the test, they got to worry, be anxious, is there something wrong, is there not? Also, blood will have that effect as well on the test. Now, there are new tests out there that blood won't interfere with it. They're more expensive. Some doctors use them, some doctors don't. So it depends on your doctor's office if they have that kind of test or not. Now, it does not mean that you cannot have any sexual contact before the test. It means you cannot have vaginal intercourse. What will interfere with it is sperm in the sample. That's it.
So what about like with a vasectomy where there is no sperm?
Well, if there's no sperm, then I guess that'll be okay. Because it's just sperm. Now, the only caveat to that, there is still semen, and I don't know if semen would, that it still is fluid. So I don't know if semen would interfere or not. That's just a good question. I'd have to verify. I'd have to kind of clarify that. But I know sperm and possibly semen will show up as ASCUS, abnormal cells of unknown significance. So, good question, but I would need to clarify that. Okay, so make sure that you remember your patient teaching. That's really important patient teaching for a Pap test. Make sure the patient is aware of those things or the test won't be accurate. Okay, so now with the last part of this chapter, we're going to move on and talk about, and I know Dr. Sears touched on this a little bit, or if she hasn't, she will be. I can't remember what she taught, but she hasn't. But violence against women. Pregnancy, the reason I want to talk about it is because it's magnified during pregnancy so much. If there's going to be violence in a household, pregnancy seems to bring it out for whatever reason. Up to a quarter of women will experience some kind of intimate partner violence in their life. In this country, that's a lot of women. 25% of women. A lot. It can happen in any socioeconomic class. It does not just happen to people that are poor. It happens to people in all socioeconomic classes. It's a cycle. And your textbook has this picture where it's a tension building and it gets worse and it gets worse and it yells and it yells and it yells. And then there is the incident where he pushes you or knocks you down or hits you. And then there's the honeymoon phase where I'm so sorry, I'll never do this again. Send you flowers, take you out to dinner, make it up to you, and then it starts all over again. And it is a clear cycle. Usually abuse is not random, it doesn't come out of nowhere, and it's not constant. It's a cyclical thing that happens in a predictable cycle. Alcohol and drugs are often involved, but not always. Alcohol and drugs usually will precipitate the problem. They don't necessarily cause the problem. Battering will become worse during pregnancy, sometimes even like threatening. You see you've got little stars there. If you see them have stars beside something, I would make note of that and make sure that you read that again, more than once. Why does battering become worse during pregnancy? Well, for good or for bad, pregnancy is a stressor. Even if you plan a pregnancy, it's still a stressor. I don't know how many of you all have kids, but probably even if you plan children and you're so excited, and the day you find out you're pregnant, you're like, oh my gosh, what have I done? Well, what have I done? Maybe I shouldn't have done that. It's too late then, but you're so excited, you want to be pregnant, and all of a sudden, oh my gosh, what was I thinking? That was the dumbest thing ever. Because it's a stressor. A man may be jealous of the baby. Pregnant women get lots of attention. Oh, you're having a baby. Can I touch your belly? Is it a boy? Is it a girl? So there's a lot of attention drawn to his female that he doesn't like or may not like. Again, pregnancy, for financial reasons, other reasons, pregnancy is a stressor. He may feel anger and frustration towards his unborn child, especially if he did not want that child. She did. And whether it's conscious or subconscious, he may hope that she loses the baby. And so, again, I'm not even saying it's really maybe conscious on his part, but, sometimes I hit with the abdomen, all the miscarriage, and, he would probably never admit it, but he's happy to see that happen. Okay, signs of partner violence. We have patients when they come in, how do we know they might be suffering from intimate partner violence? They come to the clinic or where you work a lot. You know on a first-name basis they're there a lot. But with vague, non-specific complaints, it's never anything hardly that you can put your finger on. They just come in, it's like they're there, they want something, but they don't want to say what they want. They make appointments, they miss them. When they show up one day, they don't have an appointment, but they miss other appointments. They have unexplained injuries. When they do come in injured, they don't make sense. Like, that old thing of one has a black eye, she says, I walk into a door. I've never understood that. How do you walk into a door and get a black eye? I can't figure that one out in my mind. If I walk into the door, I don't know what I'm doing, but my eye wouldn't be black. It doesn't make sense. Or they have a twisting injury on their arm, where you can see where there's marks on their arm where someone's twisted their arm. And they're bruised in like fingerprint marks. That's unexplainable. How do you explain that? They have things and stories that don't make sense, don't match up to the injuries. They may have untreated serious injuries, like you x-ray that wrist because it's bruised and you find they've got an elbow that's an old fracture that's been in the process of healing, or it's already healed. Or, you x-ray something else and find something else that's been broken. The partner, usually when they come in with the patient, they usually always come in with the patient because they won't let them go to the doctor by themselves. They never leave their side. And I've seen this happen so many times with pregnant women. They want to answer for them. They want to tell the whole story. They want to tell their whole history. They know everything about them. They even know when their last period was. How do you know? But they know. They know. They'll give you a date. They'll know everything. And the female never talks, and he says everything. That's a real big red flag right there. And again, if it's an injury, he will tell the story, not her. And he'll say, she's so clumsy. She's so clumsy. She always does stuff like this. And now she's done this. All symptoms of partner violence. So, therefore, at CAMC and most hospitals, we have a screening, not just for pregnant women, but for any women entering the hospital. The first thing that you have to do is you have to get the woman by themselves. That is key. You cannot ask these questions in front of, obviously, the suspected abuser. Nor can you ask them in front of her mother or her sister because she's probably not going to admit to them that she's being abused. So she's not going to admit to anybody. So just, well, let's ask in front of her mother. That's not probably going to work either. A lot of times these women don't tell anyone what's going on. Not their mother, not their sister, not their friends, no one. And so you have to find a way to get them alone. What we do when we have patients come to triage, we've got a little waiting area right across from them, and we'll tell them, whoever's with them, we need 10 minutes with the patient by ourselves. We've got a couple things to do, and then you can come and be with them and stay. But we need 10 minutes. And usually if you tell them that, and you say, we tell everybody this, you can kind of manage to break them up just a little bit and try to ask these questions. And the questions that you want to ask, the most important questions are very cut to the heart of the matter. Are you with someone who physically hurts you? Is your partner hurting you? Have you been hurt or injured in the last year by your partner? Have you been made to do something in the last year you don't want to do, whether it be sexually, physically, whatever the case may be? Are you afraid of your partner or anyone else who lives with you? So very specific questions that the patient can't get around and got to answer one way or the other. They got to out and out lie, but the questions are very direct, as you can see. And the patient must be alone, or this is not a valid questionnaire. Okay, so what do you not say to the patient? And this is important because if you say the wrong thing to the patient, you'll kind of scare them off. They'll go away. They won't talk to you again. They won't trust you, and you won't get the information that you need. What do you not say? Why do you stay with him? You're such a pretty girl. Why would you stay with somebody like that? What does that say to her? It says she's stupid and that she's doing something she shouldn't be doing and that you disapprove. So what she gets from that is your disapproval. So we don't say that. Don't speak negatively against her, the accuser, because what's that going to force her to do? It's going to force her to go on the defensive and defend him. Oh, but you know what? I have 2 children that are not his, and he pays for everything for them. He pays for their clothes. He pays for their doctor appointments. They're on his insurance. He's so good to me. Yeah, but he beats the you know what out of you. But he pays for all that. So they're going to defend him. The other thing that you never want to do is directly confront the abuser. As much as you may just despise their sight, you never say to them, I know what you're doing with her, you're okay. Because you may leave work that evening and find your tire slashed, or worse, find somebody in the backseat of your car waiting on you. So never, ever directly confront the abuser. Leave that to the authorities. Report it. We are mandatory reporters. If we believe somebody's being abused, we must report it. But don't ever try to take things in your hands and tell the guy what you think of him. Or even tell him you're going to report it. You don't even tell him you're going to report him. You tell him that, and again, he may decide, no, you're not going to report it. So make sure that you don't. I do know of a case where somebody got the tire slashed, who they thought was, they had said something to someone who was abusing their girlfriend, and they suspected that was the person who did it. Well, we don't know that for sure, but I'd say it's probably a pretty safe bet. And so what we want to assess with the woman is how ready, it's they kind of have to get to a point where they're ready to break away. And the first time they seek care, they may not be ready. And until they're ready to get away, you can't do much except just continue to encourage them. If they admit to being abused, you say, how serious are you? Are you ready to get out of this situation or not? If you're not, let me know when you are ready. When you're ready, I can help you. So you refer them to, there are all kinds of information and places where they can call and safe houses where they can get hooked up with. And you have information that you'll give to them, help her create a plan, tell her, start putting a little bit of money away, $5 a week, whatever you can. Make sure you have enough of your prescription put away. Get some clothes in a bag so that if the situation becomes available, you can get out quickly. And help her create a plan if you have the chance, the opportunity to talk to her. And stress that the most important thing in the world is that I don't care what else happens, we want you to be safe. So the most important thing is that you are safe. And so, again, most places we've got pamphlets that we can give them numbers to call, that they can talk to someone who's a professional who can help them to get a plan together and have a number to call where someone can literally come and pick them up. We'll meet you at the Rite Aid down the street with your bag, with whatever the plan may be. So when she's ready to start really creating a plan, that's when she's ready. Up until that point, she just talks about it, she's probably not ready. And there's not a lot you can do if a woman's not ready to leave a situation. There's unfortunately, not a lot you can do. Okay, so let's get a little bit into chapter 5, and then we'll take a break in about 15 minutes. This chapter is infertility, contraception, and abortion. Okay, infertility, contraception, abortion. Obviously, the concepts that we're talking about, which are going to kind of flow throughout most of these lectures, at least early on, reproduction and sexuality. Once we start talking about actual pregnancy, we'll be looking at other concepts like perfusion, nutrition, gas exchange, other things. But for now, it's mostly going to be reproduction and sexuality. Okay, so the first part of this chapter is about infertility. So infertility is the inability to conceive and have a pregnancy when desired. And it affects up to 15% of couples of reproductive age. And the definition of infertility is if you're under 35, you've had unprotected intercourse for a year, or if you're over 35, you had unprotected intercourse for 6 months. The reason why we break that out, and that's fairly new, is because if you're over 35, the honest truth is time is not your friend, and we really have to get on the ball. So if you're over 35 and 6 months you still have not have unprotected sex, you still haven't gotten pregnant, we're more aggressive about getting you in and getting you some treatment. If you're under 35, you've got more time, you're still younger. Fertility drops precipitously in your 30s, believe it or not. Do you know that from age 25 to, I can't remember, 30, I think it's to 35, your fertility drops by like 80%. 80% as a female. I'm talking about females, not males here, females. That's amazing. You're the most fertile in your life in your early 20s. And after 30, even though you're still ovulating regularly, your fertility drops very significantly. Because what happens is this. You start to have more cycles that are anovulatory. Your periods may become more irregular, especially in your late 30s. And remember that a female has all the eggs she's ever going to have the day she's born. All your eggs are in your little ovaries the day you're born. And so the older that they get, the more they've been exposed to teratogens, pesticides, chemicals, drugs, medications. So you've got more old, faulty eggs, and you may release a bad egg 1 month, and pregnancy does not occur. So the older that you get, the more of your fertility is affected. The term fecundity is a term that your textbook discusses, and the definition of that term is the chance. What are the chances of a couple achieving pregnancy and subsequent live birth within one menstrual cycle? So basically, what are the chances that you have one sexual interaction, and from that comes a pregnancy and a subsequent live birth. What are the chances? The chances in a normal healthy couple are about 20% that any one encounter is going to end in not just pregnancy, but then subsequent live birth. Actually, there's what I was looking for here. Fertility rates in women that are 40 to 45 are 95% lower than women ages 20 to 24. So in that 20-year period, your fertility drops by 95%. That's pretty amazing. Not to say you can't get pregnant in your 40s, but it is far, far less common. Even in your 30s, it becomes somewhat less common. In your 40s, it's very significant. Now, you know that in this country, we really are having a trend of women having babies as, older, first babies. A lot of women have careers, and they want to do their career first, and they want to get ahead and do everything they want to do, and have their babies later. And that's okay, with one exception. There's no guarantee you can have babies later if you want to wait till your 40s. Now, what they will tell you on TV and TV stars, I've heard them say this, and it kind of makes me angry because they'll say, women need to know they can wait. They can wait till their 40s. There's all kinds of options out there. Yeah, they cost $20,000, $30,000, $40,000. So if you have that kind of money, yeah, you might have the option of freezing your eggs and saving them, or having in vitro fertilization, or all these things that you can have, but they're extremely expensive, and insurance doesn't pay for those kind of treatments. So if you're wealthy, yeah, you may have options. But for those of us normal people, waiting to have babies until you're in your 40s is very risky. Very, very risky. I can't tell you how many people I know who waited and now have infertility issues because they waited until their fertility, was not at its peak anymore. And they'd like to have kids, and it's, not working out for them. So what's your place as a nurse? Where do you come in? What do you do for patients and couples who are struggling from infertility? First of all, provide accurate information about their specific diagnosis. If their diagnosis is that the female has endometriosis, then you teach them about what endometriosis is. Doctors are not good at teaching patients about the disease process or what to do about it, or how to handle it. Nurses are, and so that's part of your job. And then strategies for overcoming infertility, helpful hints, tips like that. Look for support groups. A lot of times, a support group is the best thing for a couple suffering from this or that, whatever the case may be. Looking for people that are in the same situation as them is usually enormously therapeutic. So whatever their issue is, if it's endometriosis, if it's whatever the case may be, help them look for a support group and recommend a support group for that specific thing. Provide emotional support. It is devastating for a couple to receive the news that they may not be able to have a baby the normal way. There is a grief process that has to ensue. The patient has to work through the grieving process. Most of you, whether you really ever thought about it or not, assume that someday you're going to have kids and you're going to have somebody to live after you and have your name. And, again, a lot of you guys are young and you haven't thought about that yet, but you will. And if you're told that you can't, it's going to be a real devastating thought. And so the grief process really has to play out before people can even make decisions about what they're going to do, what options they have. And then, of course, you're going to guide and educate about other treatments. Once you find out what kind of infertility you have, what your issues are, then you know what's going to be available for you. So we may teach them about IVF, which is in vitro fertilization, which we'll talk about all this, donor eggs, donor semen, adoption, surrogacy. Whatever the couple decides, we support them. If they say, no, I don't want any of that, we support that as well, whatever their decision is. And what's hard sometimes is, and we do see this a lot, if the man and the woman have different, like the woman wants to adopt, the man says no adoption. The woman wants to have an in vitro, the man says no. The man wants to do a surrogate, the woman says no. So if they don't agree, that can be a real issue as well. Okay, so what are the causes of infertility? Is it male? Is it female? Sometimes it's both. But if we look at male and female, some of the identified causes, what usually causes the infertility issues are as follows. Let's look at the male first. You see over here, 34% is unexplained, so we don't know. That's not good. 30% of the time, we don't know what's causing the infertility. Unfortunately, that's where that falls. The next biggest category is a varicocele in a male. Anybody know what a varicocele is? What do you think it is? Varicocele. What would you, if you were guessing, what would you guess that would be? You know what that is? You've heard varicose vein?
Is it low?
Not the term varicose. So the varicose means a dilated blood vessel. You all probably heard varicose veins. You're too young for that. Your mother has it. You may not. But your mother has it. I can promise you. Varicose veins are a dilated blood vessel that is kind of stretched out, not very functional. So in the case of a varicocele, it's a dilated, stretched out blood vessel in the leading down into the testicle. So into the scrotum. So it's a dilated blood vessel that's in the groin, leading from the abdomen down to the testicle. Okay. So if you have a dilated blood vessel, let's think about that. What's happening with the dilated blood vessel? How are you getting restricted blood flow or more blood flow in there? It's dilated. More. Okay. There's a reason that the scrotum is outside the male's body. The reason for that is 4 to 6 degrees cooler than an actual male body. So the male body is going to be 98.6 degrees. The temperature in the scrotum is 4 to 6 degrees cooler than that. That is specific and important. It's important for sperm. Sperm cannot survive in a 98.6 degree environment. It has to be cooler than that. So now if you have a dilated vessel with more blood going in to that scrotal sac, what's that going to do to sperm, you think? More blood, more warm blood. It's going to be a temperature issue. It's going to kill sperm, right? Does that make sense to everybody? So you have more blood going in. It's going to raise the temperature in the scrotal sac. It's going to kill sperm. So that is easily corrected, and it's diagnosed usually by a urologist. And my brother-in-law actually had one years ago and had it corrected within 3 months. You know, they were having a baby, they were pregnant. Once it's corrected, it's very easily corrected. So that's a varicosity in the inguinal canal leading to the scrotal sac. Now, along those same lines, so keep that in mind what I said about temperature, because we'll come back to that. Hypogonadism, that's low hormone levels, male hormone levels, immune system factors, other causes, or systemic disease. You may have cancer or another disease process or something that's just affecting your general health. Sexual factors are going to be something like inability to perform, like functional erectile dysfunction. And that basically means for whether it's trauma or whether it's a physical reason, the male cannot perform sexually. And obviously, if you can't perform sexually, then you cannot father a child. Urogenital infection, and this would be untreated STIs. Undescended testicles, very rare, to be have that diagnosed. But those are the list of the various causes in males. In females, you see 40% of the time, it's going to be ovulatory dysfunction failure. So the patient's not ovulating for whatever the reason is. There's a myriad of reasons, but she's not ovulating. If you don't release an egg that's a good, healthy egg, you cannot conceive a child. So you have to release an egg. That's a must. And then on the other side, we have mechanical factors. And those mechanical factors are things like scar tissue and adhesions. Let's say you had gonorrhea and chlamydia and didn't know it, and you had it for a year, and it scarred up your whole reproductive tract, and you didn't know you had it. So those are the two STDs that are asymptomatic. So now your whole fallopian tubes are scarred. So how's the sperm and the egg going to get to each other if there's scars everywhere? So that could be a cause right there. Or let's say you've had multiple abdominal surgeries. You have endometriosis, you've had Crohn's disease, you've just had multiple abdominal surgeries, you've got scar tissues and adhesions everywhere. Once again, if it's near the tubes, it's going to prevent the sperm and the egg from meeting each other. So that's what we're talking about with mechanical factors. And then 10% cervical factors, it's usually cervical cancer. Remember, the cervix is the door. That's the door to the uterus. So if it's damaged in any way, the door's damaged, it's going to be harder for sperm to get in through that door. So for women, it's usually one of those three things. Now, there's a lot of causes of those three things, but all those causes cause either cervical scarring of the reproductive tract, or the patient's not ovulating. It's usually one of those three things from a bunch of causes, but what boils down to three different things. Does that make sense? Questions about that? Don't try to memorize this many percent is this and this many percent is that. Don't do that. What I do want you to understand is what it means to have ovulatory dysfunction. To understand that you can't get pregnant if you don't release a good, healthy egg. That's what the can't get pregnant if you're full of scar tissue. That's really what what you need to take from this. I'm not going to ask you what percent of men have varices. It's not important in the whole scheme of things here. Factors associated with infertility. Of infertile couples, 80% will be able to identify a cause, 20% will not. So the majority of the time we can find a cause, but 20% of the time we may never know why the couple's infertile. And it might be both. Maybe we find he's got a varicocele and she's not ovulating. So now we've got two problems we have to fix. So, hopefully it's only one person or the other, we can work on fixing the problem. But a lot of times we'll do a lot of infertility, workups, and we'll find that they both have issues. It's more likely to be female than male related, although males do have the issues that we talked about. But if we had to attribute to more often one sex or the other, it's more often going to be female related. Now, some factors that will associate with fertility and infertility. Sperm can remain viable for 72 hours, that's 3 days. And in rare cases of what I call super sperm, up to 5 days. So if you happen to be a person who has super sperm, maybe they'll live 5 days, but most of the time it's 72 hours. The egg, once the egg is released, it is viable for up to 24 hours. That's from the time the egg is released from the ovary. So if the egg pops out of the ovary at 8 o'clock in the morning, it is good up until possibly 8 o'clock tomorrow. That would be the most it would be viable up to 8 o'clock tomorrow. Now, if the egg is released from the ovary at 8 o'clock this morning, and the couple has intercourse at 8 o'clock tonight, there's a reasonable chance that conception may occur. Or even if there was intercourse last night, and the egg popped out of the ovary at 8 o'clock this morning, again, there should be enough sperm left in there that would be easily to fertilize that egg. So a lot of times, pregnancy comes down to trying to figure out when a woman's ovulating and timing intercourse appropriately from that. Some of the most significant factors for achieving pregnancy are maintaining a normal BMI in male and female, especially female, but male and female, normal BMI. And a normal BMI is going to be anywhere from 17 to 27. We'll learn about that in another chapter too, but you might want to jot that down because we're going to come back to it. A normal BMI is going to be anywhere from 17 to 27. Not having STIs or their sequelae, and that means not having had sexually transmitted infections and their repercussions, which are usually scarring. Avoiding substances that affect health, such as cigarettes, alcohol, drugs. That's the best thing that you can do, to make yourself the most healthy for conception. Okay, so simple things, again, to improve chances for conceiving. Now, if someone, again, has diagnosed medical issues, we've got to address those. But there are simple things we can do to encourage patients. Try these things, and especially while we're waiting on these tests to be done. And maybe you'll get lucky. I actually know someone who thought that they always would ovulate on the 14th day. And so they timed their intercourse to conceive on the 14th day of every month. What they didn't know was it's not just the 14th day, it depends on how long your cycle is. So if a female's menstrual cycle is 33, 34, 35 days, it's a whole week later. It's day 21 if it's a 35-day cycle, not day 14. So that person was getting ready to have an infertility workup, actually a friend of mine, and someone told her this, and she readjusted when they were trying to get pregnant, and she got pregnant without ever going to the doctor for infertility because they were misinformed, didn't know the facts, and were completely timing intercourse at the wrong time based on her own specific menstrual cycles. So sometimes it's just lack of education. So we should limit intercourse to 2 to 3 times weekly to avoid depleting sperm count. You can absolutely deplete the sperm count by having sex twice a day. So what you're gonna do is minimize your chances of pregnancy because the sperm count's gonna be low enough so there may not be enough sperm to fertilize the egg when the egg is finally released. So minimize 2 to 3 times a week, and that should be strategic. So those times should be strategically planned around ovulation. So if you think you're going to ovulate, so if you think by looking at your menstrual cycles that you're going to ovulate on Wednesday of this week, then intercourse should probably be Monday, Tuesday, Thursday, or Tuesday, or Monday, Wednesday, Thursday. But it should be targeted around those days. Engage in intercourse the day before and the day after ovulation, as I said. But if you hit the day before and the day after, you're likely to have better success. And of course, it's very hard to say, oh, we're going to have sex on these days, and it does wreak havoc on relationships. And I've seen a lot of people end up in divorce over infertility issues. So you've got to try to remember that, this is, above all, not just a partnership to have a baby. This is a romantic relationship as well. And try to keep that in perspective as you're trying to have a baby. And I can't tell you how many times I've heard of people who stopped trying. They either adopted a baby or they decided they weren't going to do it anymore and they were done. And then next thing, 2 months later, they're pregnant. Because their stress levels drop, which means their cortisol levels all drop. So their stress response is gone. And all of a sudden they get pregnant. So there is something to that whole stress response in the body. All right. Okay, go ahead and take a 10-minute break. Just forgot.